Welcome to this video about anterior visual pathway demyelination. This condition, affecting the intricate network responsible for transmitting visual information from the eye to the brain, can lead to a range of visual disturbances. We'll delve into its causes, how it affects the body, and what can be done about it. So, what causes anterior visual pathway demyelination? The most common culprit is multiple sclerosis, or S, an autoimmune disease where the body's immune system mistakenly attacks the myelin sheath, the protective covering around nerve fibers in the brain and spinal cord, including those in the optic nerve and other parts of the anterior visual pathway. Other less common causes include neuromyelitis optica spectrum disorder, or MOSD, another autoimmune condition, acute disseminated encephalomyelitis, or ADEM, which is often triggered by a viral infection, and in rare cases infections, toxins, or genetic disorders. In some instances, the cause remains unknown, termed idiopathic demyelination. Now let's understand the pathophysiology. The myelin sheath acts like insulation around an electrical wire, allowing for rapid and efficient transmission of nerve impulses. In demyelination, this insulation is damaged or destroyed. This disruption slows down or blocks the signals traveling along the optic nerve, which extends from the retina at the back of your eye to the brain. As a result, the visual information doesn't reach the brain as efficiently, leading to various visual problems. The location and extent of the demyelination determine the specific type and severity of the visual impairment. Epidemiologically, anterior visual pathway demyelination closely mirrors the prevalence of its underlying causes, particularly multiple sclerosis. MS is more common in women than men, and is more prevalent in regions further away from the equator. As such, demyelinating optic neuritis, a common manifestation of anterior visual pathway demyelination, will also follow this epidemiological pattern. Neuromyelitis optica spectrum disorder has a different global distribution, and also can cause this condition. Exact numbers are difficult to pin down, as many cases are diagnosed as part of a broader neurological condition. The signs and symptoms of anterior visual pathway demyelination can vary, but commonly include optic neuritis, characterized by sudden onset of eye pain, often worsened by eye movement, and blurry or decreased vision in one eye. Other symptoms can include reduced color vision, particularly red desaturation, where colors appear washed out or faded. Visual field defects, such as blind spots or peripheral vision loss, may also occur. Some individuals experience phosphenes, which are brief flashes of light, especially with eye movement. In some cases, the condition can affect both eyes sequentially or simultaneously, though this is less common. Diagnosing anterior visual pathway demyelination involves a thorough neurological and ophthalmological examination. This typically includes assessing visual acuity, color vision, and visual fields. An ophthalmoscope is used to examine the optic disc, which may appear swollen or pale. Magnetic resonance imaging, or MRI, of the brain and orbits is crucial to visualize the optic nerve and identify areas of demyelination. Visual evoked potentials, or VIP, tests measure the time it takes for electrical signals to travel from the eye to the brain, and can detect slowed conduction due to demyelination. Blood tests may be ordered to rule out other potential causes, such as MOSD or infections. While there aren't specific classifications of anterior visual pathway demyelination itself, the condition is often categorized based on its underlying cause, such as MS-related optic neuritis or MOSD-related optic neuritis. This distinction is important because the treatment and long-term management may differ depending on the etiology. The primary goals of treatment are to reduce inflammation, speed recovery, and prevent future attacks. High-dose intravenous corticosteroids are often the first line of treatment for acute episodes. Plasma exchange, also known as plasmapheresis, might be considered in severe cases that don't respond to steroids. Long-term management focuses on addressing the underlying cause. For individuals with MS disease, modifying therapies aim to slow the progression of the disease and reduce the frequency and severity of relapses. For MOSD, immunosuppressant medications are used to suppress the autoimmune response. Symptomatic treatment, such as low vision aids and rehabilitation, can help individuals cope with any residual visual impairments. Unfortunately, there's no guaranteed way to completely prevent anterior visual pathway demyelination, as many of its underlying causes are autoimmune in nature. However, managing risk factors associated with MS, such as vitamin D deficiency and smoking, may be beneficial. Early diagnosis and treatment of conditions like MS and MOSD are crucial to minimize the risk of optic nerve damage. The prognosis for anterior visual pathway demyelination varies depending on the severity of the initial attack, the underlying cause, and the effectiveness of treatment. Many individuals recover significant vision after an acute episode, but some may experience residual visual deficits. Recurrent episodes are common, particularly in individuals with MS or MOSD. Recent research is focusing on developing new and more effective disease-modifying therapies for MS and MOSD, as well as investigating potential regenerative strategies to repair damaged myelin. Clinical trials are also exploring the use of optical coherence tomography, or OCT, to monitor optic nerve health and predict future relapses. The future holds promise for improved diagnosis, treatment, and long-term outcomes for individuals affected by anterior visual pathway demyelination.